invite Dr. Girija ma'am to introduce Dr. Charles sir, senior consultant and diabetologist.
Hello. Dr. Charles Bronson is a diabetologist at the Institute of Diabetology, Stanley Medical College Hospital in Chennai. He is a visiting consultant diabetologist in CSI Kalyani Hospital, Chennai Meenakshi Multi-Speciality Hospital and St. Isabel Hospital, Chennai. Graduated from PhD Institute of Medical Sciences, Coimbatore, and did his PG in diabetology from MMC. He is the recipient of Shankaran Memorial Award for Best Research in MBBS in 2007. Also received Professor Sam G.P. Moses University Gold Medal in Diabetology in 2013. He is an associate editor of the Curious Journal of Medical Sciences. He is a member of the ADA International Society for Pediatric and Adolescent Diabetes and Executive Committee member of Diabetes Association of India Southern Chapter. He has published over 20 scientific papers and book chapters in the field of diabetology which have been cited internationally. He is here to talk about an important topic, complications of diabetes mellitus type 2. Over to you.
Thank you for the kind words of introduction, madam. Respected Dr. D.Diab sir, respected Dr. Ramamurthy sir, respected senior members of IMA, colleagues, friends, a very good evening to everyone. I thank you very much for kindly inviting me to join you on this wonderful evening and to discuss an interesting topic on the complications of diabetes mellitus. So, as we know, and this topic is, as you know, is a very wide topic, and we'll try to cover up as much as possible. We'll have a brief overview of everything. We will also have clinical vignettes, some practical points on how to deal with things, etc. And diabetes mellitus, as something like the communicable disease pandemic, as we saw in COVID, in the last few decades, it has become a non-communicable disease pandemic. And the recent International Diabetes Federation data shows that in the age group of 20 to 79 years, about 10.5% of the world's population is affected. In other words, about 1 in 10 people in the world in this particular age group are affected with diabetes. And of all the live births, about 16% of all live births are affected with hyperglycemia and pregnancy. And therefore, to every physician, to every practitioner, or even every surgeon, everyone of every specialty, knowledge of diabetes and its complications is essential. Coming to the complications of diabetes, and these complications may broadly be categorized as acute complications and chronic complications. And first we will see about the acute complications. Acute complications, when we say we are talking about three things, that is hypoglycemia, diabetic ketoacidosis and hyperglycemic hyperosmolar state. The first thing is hypoglycemia. Hypoglycemia more often than not is a therapeutic adverse effect. So it needs to be corrected based on the severity. Hypoglycemia doesn't occur by itself. It is nothing but an adverse effect due to our intervention, and it needs to be corrected based on the severity. Based on the severity means whether the patient is conscious, alert, and based on that we have to correct the hypoglycemia. For an unconscious patient or a patient who is throwing fits, we should give correction by IV route. Suppose the patient is stable, we can even take oral routes. And people like the elderly individuals and alcoholics are more prone to develop hypoglycemia, especially when the other drugs are taken. And these are some factors that cause hypoglycemia in people with diabetes. For example, an incorrect dosage or medication, or an insulin food timing mismatch, or more amount of exercise than what he normally does, and delaying the meals or skipping the meals, lack of sufficient carbohydrate, taking only a lean diet, etc. So, and we'll also go through some of the finer points. Even though we are talking about good glycemic control and everything, there has been some studies that show that unnecessarily tight glycemic control, especially achieved during a shorter span of time, it was associated with higher mortality. For example, in this ACCORD trial, which was a large study, when strict glycemic control was achieved within a short span of time, for example 6 months, with the HbA1c of less than 6.5 with the many hypoglycemic episodes in between, it led to an increased mortality. And also, we should remember that as the hypoglycemic episodes, they affect the quality of life of the patient. And also, repeated hypoglycemic episodes have been shown to affect the cognitive function of the patient. And another practical point is that suppose we are having a patient, dealing with a patient, so, and he has been on a particular set of medications for diabetes for a particular duration of time. Suddenly the patient is experiencing some amount of hypoglycemic episodes. Now and then he is having some symptoms of hypoglycemia and coming to us. Then it means that the first thing we have to ask about after the general history, whether the patient is taking diet at the appropriate time, etc., etc. The first thing we have to think about is there could be a deteriorating renal function that is lying behind the screen. So coming to the next hyperglycemic emergency, it's diabetic ketosis or diabetic ketoacidosis. Diabetic ketosis simply means the patient is usually stable and there is no acidosis. That is, in the ABG there is no acidosis. And ketoacidosis, that is DKA, means there is hyperglycemia, ketone body synthesis as well as acidosis. So it is DKA is an acute hyperglycemic emergency. DKA can present in type 2 diabetic patients because sometimes they may skip the medication for 1 month or 2 months and come with very high blood sugar and some stressful events, for example, an infection, a cellulitis, a necrotizing infection or a myocardial infarction, everything can produce diabetic ketosis or DKA in a type 2 patient. However, in a type 1 diabetes patient, many a time it is the first presentation in a type 1 diabetes patient. And these type 1 diabetes, throughout their life, they will have many episodes of, they are likely to have many episodes of diabetic ketosis or diabetic ketoacidosis, mainly due to skipping insulin or an insufficient dosage of insulin, some incorrect technique of insulin or other stressful event. And how about the management of DKA? Usually in the DKA, significant dehydration is present, about 10% of body weight might be lost. So in such cases, rehydration is the first point of therapy, and there should be electrolyte correction, especially the correction of potassium, as there could be hypokalemia, and accompanied by insulin therapy. And despite the best efforts, even in these modern times, DKA carries a mortality of about 5 to 10%, even in the best of institutes. So the third acute complication is hyperosmolar hyperglycemic state or hyperglycemic non-ketotic diabetic coma. It was previously called like that. It is another acute hyperglycemic emergency. It is characterized by a very high blood sugar, hyperosmolality, dehydration, thirst, altered sensorium, etc. And usually it occurs in elderly patients with poor mobility. They have a lesser access to water intake. They do not have good caretakers. They might not be in the best of senses, etc. And sometimes it is the initial presentation of type 2 diabetes. And here also the treatment involves rehydration, electrolyte correction and insulin therapy. So this is a figure that shows Venn diagram showing the properties of DK and HHS. Both have hyperglycemia, but here the ketosis is prominent and the metabolic acidosis is prominent. Here the prominence is with high serum osmolality, absent of significant ketosis, and altered sensorium that is prominent in HHS. And having seen this, we'll have a brief look at this clinical vignette, what we call as euglycemic ketoacidosis. Here we saw what is a diabetic ketoacidosis, that is a hyperglycemic ketoacidosis. Here there is a phenomenon called euglycemic ketoacidosis. This came into prominence after the arrival of the drugs SGLT2 inhibitors. What is the difference between that and this is, in DKA there is hyperglycemia. This hyperglycemia is due to an absolute deficiency of insulin, especially in a type 1 diabetic patient. And this absolute deficiency of insulin leads to an uncontrolled lipolysis in the adipose tissue, and because of this excessive lipolysis, the fatty acids go to beta oxidation. When beta oxidation becomes exhausted, they go for ketone body synthesis. This is what happens in DKA. But what happens in SGLT2 inhibitor therapy is that SGLT2 inhibitors act via the kidney and they cause glucose to go out through the kidney. And this causes glycosuria, and because of the glycosuria, blood glucose comes down. As we know, blood glucose is the main stimulus or the major stimulus for insulin secretion. So, in contrary to natural effects, as blood glucose comes down because of glycosuria, the pancreas senses this to be a lesser amount of blood sugar, and it thinks that it should secrete lesser insulin. Okay, so lesser insulin leads to an increased lipolysis. Again, it goes to beta oxidation, and when beta oxidation is exhausted, there is an increased ketogenesis and leads to euglycemic decay. This euglycemic decay is important when the patient, sometimes when the patient is posted for surgery. Suppose in this summer months when the patient, an elderly patient is taking this SGLT2 inhibitors, and these patients can go for euglycemic decay and they should be monitored. And having seen the acute complications, now we enter the chronic complications. And chronic complications is an extensive term that encompasses all long-term adverse effects of diabetes. Diabetes, as we know, affects almost all the organ systems of the body. Ultimately, diabetes exerts its efforts because it's an angiopathy, that is, affects the blood vessels. And the chronic complications can be categorized broadly into two, that is, microvascular complications and macrovascular complications. And coming to the microvascular complications, we have diabetic retinopathy, diabetic neuropathy, diabetic nephropathy. As we see, all these complications have the epithet of diabetic. So it means that these complications are more specific for diabetes. That is, when I say diabetic retinopathy means it is because of diabetes only. And it's more specific for diabetes, however, with a considerable role played by other comorbidities like hypertension and dyslipidemia. On the contrary, macrovascular complications like coronary artery disease and heart failure, usually earlier they used to focus only on CAD, but nowadays heart failure is also being given due importance. And heart failure, the incidence of heart failure is also high in diabetic patients when compared to non-diabetic subjects. And with the arrival of SGLT2 inhibitors, the treatment of heart failure, the prevention of heart failure in a type 2 diabetes patient has assumed a lot of importance. And coronary artery disease and heart failure, macrovascular complications, cerebrovascular diseases, peripheral vascular diseases. Here it has got a multifactorial etiology. It is not specific for diabetes. Diabetes is a part of the multifactorial etiology that causes this macrovascular complications. And furthermore, even though we have categorized like that, there are so many other complications also. For example, the important diabetic foot and the most severe form of diabetic foot, that is the Charcot foot or the Charcot neuroarthropathy. And there are a lot of infections affecting all the systems of the body, starting from the eye, starting from the skin, soft tissue, kidneys, gallbladders. There are so many cutaneous manifestations, bone and rheumatological disorders, gastrointestinal manifestations like gastroparesis, diarrhea, non-alcoholic fatty liver disease, etc. And more importantly, a secretive complication, that is sexual dysfunction, present in many individuals who do not disclose it to the clinician. And ultimately, many patients are depressed also. And having seen this introduction, what are we going to see in this presentation? We'll have a brief overview of the complications of diabetes, and after that we'll have some clinical practical points, in the clinic. How to go about the assessment, how to or when to screen for comorbidities, why to intervene, and how to prevent these complications. And first thing is, we'll have an overview. And when we are talking about the complications, when diabetes per se is considered, what is the risk factor, or what are all the risk factors that lead to the evolution or the progression of diabetic complications? The first and foremost risk factor is the duration of diabetes. All diabetes complications are directly proportional to the increasing duration of diabetes. The second thing is the degree of control of hyperglycemia. Probably a well-controlled person could have a lesser risk of developing diabetic complications. And associated comorbidities like hypertension, dyslipidemia, smoking, hypothyroidism all have an effect. And having said that, biochemically there are so many pathways, like pathogenetic pathways are proposed for the occurrence of these diabetic complications, like the polyol pathway and the deposition of advanced glycation in products in the near the vascular endothelium, in the extracellular matrix, everything. And ultimately, it's nothing but a free radical damage that occurs to the endothelium. This we have to remember. Free radical damage is what the basic underlying pathology in diabetic complications. And having said this, I have put a word like we have to be mindful of novel clusters, because here I have said that duration of diabetes is important in the causation of complications. But nowadays we are seeing so many patients, like there is a difference of opinion that there are other categories of patients also, especially some young patients around the age of 40 years or something. They have a tendency to develop insulin deficiency, even though they are treated as type 2 diabetes. They have a tendency to develop insulin deficiency, and they rapidly develop complications like retinopathy and nephropathy. And we have to keep in mind this novel clusters people, and we have to try to catch the complication at the earliest stage. Coming to diabetic retinopathy, and this is an illustrative example of a normal retina. Here we see the macula, fundus and everything. And in diabetic retinopathy, this is just a schematic diagram of here we see hemorrhages. Here we see cotton wool spots, aneurysms. Microaneurysms are a classical feature of diabetic retinopathy. Another area where we see microaneurysm in diabetes is a specific pathology called diabetic cardiomyopathy, where the intramyocardial small capillaries, they might have microaneurysms. And this is a hard X-ray. And this is a non-proliferative diabetic retinopathy. Here there is an aneurysm, hemorrhage, hard X-ray. But the difference here is there is a growth of abnormal blood vessels near the disc or away from the disc, and there is bleeding inside the retina and leads to the vitreous. This is proliferative diabetic retinopathy. There are so many classifications and each country adapts its own classification. It differs between the ophthalmologists also. Usually they say there is no diabetic retinopathy, then they go for mild non-proliferative, mild NPDR, moderate NPDR, severe NPDR, and then they go for PDR. And along with this, there is a phase called clinically significant macular edema or CSME. It could be associated with any of these. Suppose a patient with moderate NPDR can have macular edema. A patient with PDR can also have macular edema. This is another way of classifying diabetic retinopathy: background retinopathy, pre-proliferative, proliferative, maculopathy, etc. And coming to the management of diabetic retinopathy, as with any other complication of diabetes, the first and foremost thing is a good glycemic control, the control of other comorbidities like hypertension, dyslipidemia, and when the lesions progress, especially when there is neovascularization, photocoagulation comes into picture. There are certain treatments, certain injections like intravitreal angiostatic treatment, injection of steroids, triamcinolone, etc. to control the macular edema. And the popular thing, the bevacizumab, the Avastin, it is an anti-VEGF, vascular endothelial growth factor. It is also tried to control proliferative diabetic retinopathy. And in the final stages, sometimes the bleeding might be more, bleeding could not be controlled, and invasive things like vitrectomy might be needed. Next thing is diabetic neuropathy. As we see, it's a very common presentation. Sometimes even during the initial presentation of the patient to us, the patient might have this complication. And it could be even the first presenting feature. And coming to the symptoms, there are two types of symptoms in neuropathy. Some patient might say, I am having a numbness of feet, I don't feel anything. They ask the patient, they'll typically say, I have a feeling of walking over cotton or walking over a paper, as if having a paper under my feet. Or some patients may say, I feel my feet to be heavy. And unlike previously, the feet appears to be heavy. All these things are signs and symptoms of diabetic neuropathy. And these are negative symptoms. This numbness, all this loss of sensation are negative symptoms. And there are other symptoms like positive symptoms, for example, like burning sensation, pricking sensation. But among the two, which is more dangerous in the idea? The positive symptom or the negative symptom?
Negative.
Yes, sir. As you said, negative symptoms are more dangerous because at least with the positive symptoms, the patient might be aware that it's having some kind of diabetic neuropathy and having an insensate foot or an at-risk foot. But with the negative symptom, the patient might even prick on some sharp object and might not even feel it until it develops into a big ulcer. And lengthy nerve fibers are more prone. That is why the feet or the legs are more prone. And diabetic neuropathy, it follows a protracted course. It follows, even when you initiate treatment for the drugs to take effect also, it takes 2 weeks at least. So this is just a picture of the pattern of diabetic neuropathy. This is the distal symmetrical polyneuropathy of the glove and stocking pattern. And this is an example of a radiculopathy or a plexopathy pattern. And this is an example of a mononeuropathy pattern, like a mononeuritis pattern here. And this denotes an autonomic neuropathy pattern, which includes cardiac autonomic neuropathy, gastroparesis, enteropathy, etc. And this is another picture simulating the same thing. There is a classification called large fiber neuropathy, small fiber neuropathy. This is a proximal motor neuropathy also happens. It is called femoral neuropathy or diabetic amyotrophy. Another term is there. And sometimes this is acute mononeuropathies. They happen, and entrapment neuropathies also are common in diabetes, especially sometimes it happens in pregnancy. The median nerve might get entrapped, and the legs also some nerves get entrapped. And this is an illustrative picture. Ultimately, as I said, diabetic complications are nothing but angiopathies. And here there is an ischemia in the vasa nervorum. And here it leads to axonal degeneration, reduced Schwann cell transport. There are biochemical and genetic abnormalities. And in very severe cases, demyelination also occurs, even though demyelination is not typical of diabetic neuropathy. And coming to management, this is easily picked up clinically itself. And physical examination and history, they pick up the findings. And to confirm, we might do a nerve conduction studies on rare cases and biopsy, etc. And usually these are not needed. Clinically itself, we can pick it up. And ultimately, glycemic control. And if the patient is smoking, ask him to stop smoking. Other comorbidities control. And drugs like amitriptyline, duloxetine, pregabalin, and some mild opioids like tramadol and topical capsaicin, and nothing works, electrical spinal cord stimulation, etc. are there, but not done many practical clinical settings. And so treat things like diabetic gastroparesis, drugs like levosulfuride can be used. And here a clinical vignette is, suppose if the patient is having a diabetic gastroparesis, using a drug like the GLP-1 receptor agonist can worsen the diabetic gastroparesis because these drugs delay the gastric emptying. This has been put up in the it is a well-known complication with the GLP-1 receptor agonist, so we might avoid it. But the same thing happens, it's not DDP4, it's actually DPP4. And the same thing happens with DPP4 inhibitors also. Sometimes the patient might have a diabetic gastroparesis and we might think that DPP4 inhibitors might not worsen it. But they usually do, especially if the patient has got pronounced diabetic gastroparesis, DPP4 inhibitors, that is the oral drugs, they can also worsen the diabetic gastroparesis. Now coming to the diabetic nephropathy, the diabetic nephropathy or the diabetic kidney disease correlates well with the duration of diabetes. It usually occurs, it takes a long time, it usually takes 20 years or 25 years for this complication to occur. And as we know, diabetes nowadays is the leading cause of end-stage renal disease in the world. And diabetic nephropathy may show a familial clustering. This complication is shown to inherit through genetic pathways. And many times we think that as we measure the serum creatinine, like we think that is 1.2, it's normal, 1.3, a little tipping is also normal. Measuring the creatinine alone will not reflect the actual pathogenesis. A creatinine elevation is usually late effect. And for a practical point of view, except in a muscular male or a heavily built or a tall male, in our population generally, whenever we see that the creatinine is tipping to 1.2, 1.3 itself, even by looking at that a few repeated values, we can assume that it is not normal. And in a normal creatinine will be like 0.8, 0.9 only. Whenever it's dipping to 1.1, 1.2, 1.3 and all, next time it will be 1.4 only. So the creatinine elevation itself, it's a late effect only. We cannot rely on that being diabetologist. So EGFR measurement is more reliable clinically. We will be surprised when we use the EGFR apps like the CKD-AP app or the MDRD app or the Cockcroft-Gault formula app, whatever it is. When we use those formulas, we will be surprised when we will be having a patient with 1.1 creatinine and we'll have the patient's age might be 65 years and we will think that everything is normal, but when we put that same value in the EGFR app, we will find the EGFR will be like very low, it will be like 45 or something like that. So albuminuria is an early marker. So to detect diabetic nephropathy, we should monitor or measure urine albumin. And certain clinical points are that usually, suppose if you would like to know some diabetic nephropathy is really diabetic nephropathy, what we do or what the nephrologists do is we should check for the fundus. Suppose if there is the presence of diabetic retinopathy, we can assume that the nephropathy is diabetic nephropathy. However, that is not necessarily needed in all cases. But this is a guiding point. Suppose if you have a diabetic retinopathy and I have a nephropathy, I can say that is diabetic nephropathy. But if there is no retinopathy and there is nephropathy, it doesn't mean that it is not diabetic nephropathy. So the reverse is not true. And also, usually there is proteinuria in diabetic kidney disease. But there are also cases where there is a non-proteinuric diabetic kidney disease. And diabetic kidney disease complicates treatment as well as the quality of life. Everything will be going on fine for the patient, but once the creatinine elevation or the EGFR becomes low, the same treatment becomes a burden with frequent hypoglycemias. So frequent hypoglycemic episodes with the previously acceptable treatment should trigger the suspicion to the clinician about a possible worsening renal function. And this is just an illustrative diagram of the typical nodular glomerular sclerosis. It is not necessarily present in every patient. The pathology varies actually. There are so many presentations. But this is the typical diabetic pathognomonic lesion of Kimmel-Steele-Wilson nodules. And we have a clinical vignette here. How to detect a non-diabetic kidney disease in a diabetes patient. The non-diabetic kidney diseases could be very well present in a diabetes patient. They might be coexistent. So how to suspect that? So indicators of non-diabetic renal disease in a diabetic patient, the absence of retinopathy, especially in the type 2 but as I told you, it is not a dictum. The thing is that the sudden rapid onset of proteinuria, a disproportionate onset of proteinuria. Diabetic nephropathy follows a long protracted course. It is not a rapid or a sudden worsening or sudden onset of proteinuria. And the duration of diabetes when it is less than 5 years. And there is sometimes a macroscopic hematuria or the passing of casts in the urine. And the rapid decline in renal function, the renal dysfunction, without even significant proteinuria, and greater than 25% decline in the eGFR, even despite of RAS blockade and other abnormalities. So we might even have a non-diabetic kidney disease in a diabetes patient. In that case, we have to, the final diagnosis will be given by renal biopsy. Suppose if the nephrologist is in doubt, he can go for a renal biopsy. So coming to the management, it's a measurement of urine albumin, microalbumin and albumin creatinine ratio, blood urea creatinine, eGFR and ultrasound to assess the kidney size. In the early stages of diabetic kidney disease, the kidneys will be either normal in size or even enlarged in size. They are usually not contracted. Suppose even in the early stage the kidneys are contracted, means that itself might trigger a suspicion of a non-diabetic kidney disease in a diabetes patient. And the treatment includes RAS blockade, renin-angiotensin system blockade, including the ACI inhibitors and the AR blockers. And the management of hypertension is very crucial. Whenever we start seeing albuminuria, even more than the diabetes control, the control of hypertension is very important. It is what that causes the progression of the disease by increasing the intraglomerular pressure. And nowadays, the drugs like glyphosate, like especially dapagliflozin, they have shown to have some benefit in microalbuminuric patients. That's in the early stage of albuminuria. They have been shown to retard the progress to some extent. And finally, we have the renal replacement therapy like dialysis, and finally we have the transplant. As clearly put forward by late Professor Sam G.P. Moses, diabetic nephropathy is a costly complication of diabetes mellitus. And finally, coming to the macrovascular complication, this is the chronic complications of diabetes, which includes affects the heart, the central nervous system, and even the peripheral arterial disease. And as I said earlier, it has got multiple etiologies. Here, diabetes is not a specific factor. The etiologies include increasing age, poor lifestyle, overweight, history of smoking, history of diabetes, hypertension, dyslipidemia. And management includes lifestyle measures, diet, exercise, following a diet like a DASH diet where there is a lot of green leafy vegetables, lesser amount of salt, etc. And the targeted intervention. For example, if the patient is smoking, the first intervention to be ask him to stop smoking. Smoking has got a deleterious effect even after so many years of stopping the smoking. So you have to immediately stop smoking. And specific therapies for suppose the diabetes is there, treat diabetes, hypertension, treat hypertension, and statin therapy. For all diabetes more than 40 years of age, statin should be advocated. And periodic assessment of certain indicators like actual brachial index, ECG, echo, treadmill, Doppler, everything should be done. And coming to the other complications, the diabetic foot. Diabetic foot is a very important, very common missing complication. When we say diabetic foot syndrome or a diabetic foot, there are three components. One thing is a vasculopathy, another thing is a neuropathy, and the third thing is an infection. So vasculopathy and the neuropathy are underlying things, and the infection is the superadded thing which causes this diabetic foot syndrome. And this is an example. For example, the grade 1 is a superficial ulcer, grade 2 is going to the subcutaneous, and grade 3 are deeper ulcer. Here they are showing how these leukocytes etc. are engulfing the blood vessels, the endothelium etc. In other words, in this slide what they are trying to convey is why the wounds are not healing. That is, the patient usually asks us, I am having a wound for a long time, and the wounds are not healing. And what they say is diabetic foot ulcers do not heal because they are frozen in a chronic inflammatory state. Diabetes is something like a subacute inflammatory state. The reason why the diabetic foot ulcers are not healing is because they say that they are something like they are frozen, they are held up in a chronic, non-progressing inflammatory state. It is neither progressing this way or that way. So this is a common complication. And Charcot's foot or Charcot-neuroarthropathy is an advanced complication. It starts here. There is a severe neuropathy, that is autonomic neuropathy, sensor neuropathy, motor neuropathy, and the bone and the foot ultimately becomes something like a bag of bones appearance in the X-ray. There's a severe loss of sensation. The foot becomes deformed, and it assumes what is called a rocker bottom foot appearance. Earlier they used to say that leprosy is the predominant cause of Charcot's foot, but nowadays diabetes has become the predominant cause. Syphilis also, nowadays diabetes has become the predominant cause. And coming to infections, diabetes can predispose to infections any part of the body. I'm just highlighting a few important things. This is a STI, a very common presentation in a diabetes patient. And this is tinea corporis. This is the dermatologist put it like extensive dermatophytosis, that is what they write, and this is tinea corporis. And many a time, the patient presents to the dermatology clinic with such findings, and it is the dermatologist who asks the patient to do a blood sugar testing, and he gets to know that he is diabetic. And this is cellulitis. Cellulitis is subcutaneous tissue superficial infection, very common in a diabetes patient. Unless treated aggressively, because sometimes it may even progress to sepsis. And necrotizing fasciitis, usually the lesions are actually very gruesome. For the sake of not showing gruesome pictures, I put the illustrative example. It's a deep infection. And severe necrotizing fasciitis, especially with Clostridium infection, it is called a gas gangrene. Here the surgeons are in a lot of trouble. They have to do an immediate debridement and a severe thorough debridement, and they have to save the patient's life. And recently we are seeing more and more cases of Fournier's gangrene also, which is nothing but necrotizing fasciitis of the perineum. We've been seeing a lot of Fournier's gangrene. So there's also a surgical emergency. And here we have emphysematous pyelonephritis. The emphysematous pyelonephritis is a typical infection associated with diabetes mellitus. And here emphysematous cholecystitis. And furthermore, coming to the cutaneous manifestations, here we have a typical cutaneous lesion. This is called necrobiosis lipoidica diabeticorum. This is initially it starts at erythematous plaques. It typically occurs over the shins. Later the erythematous plaques become atrophic, and on the center they have an yellowish pigmentation. In the edges there is erythema, raised edges, and telangiectasia. NLD is almost pathognomonic or typically associated with the diabetes. And whenever we say that this skin complications are occurring, we indirectly mean to say that there is a microangiopathic process which is going on, or a vascular angiopathy process which affects the other vital organs is also going on inside the patient. And this is a diabetic dermopathy or the shin spots. This is very common. Studies say that around 50% of diabetic patients will have this shin spots. And this is this thickening of the skin over the back, especially over around the neck. This is called sclerodema diabeticorum. This is also quite common. I am only putting up selected pictures, selected examples of each and every condition. And this is another interesting thing. This is called a diabetic cheiroarthropathy. Cheiro means hand, and arthropathy, which means that because of chronic hyperglycemia, because of uncontrolled hyperglycemia, and because of the formation of advanced glycation end products. Advanced glycation end products are nothing but non-enzymatic glycosylation of proteins in the extracellular matrix, etc. So these advanced glycation end products, they get deposited in the hand, the connective tissue, and everywhere. So when the patient tries to do like this, normally he should be able to approximate. So these two fingers should be able to approximate. Here the patient is unable to approximate this finger. So this is called a prayer sign, as if the patient is praying to God. So this prayer sign indicates that the patient has got microangiopathy or microvascular complication. So if the prayer sign is present, we might need to screen for other vascular complications, including micro and macrovascular complications. All these are corroborative evidences or indirect evidences of what is going on inside. And I have made it short. The gastrointestinal complications of diabetes, this includes, very commonly it includes diabetic, suppose that sometimes the patients have diarrhea, sometimes the patients have constipation, both can occur. Gastroparesis is a very troublesome complication. The patient says that I eat only 2 idlis and I feel a sense of fullness, a sense of bloatedness. We are at a fix. We actually do not know what to do at that point of time. You have to reassure the patient. The patient might sometimes they need to take small frequent meals, and drugs like levosulfurate could be used, and everything should be accompanied by a good glycemic control. And non-alcoholic fatty liver disease, it is commonly associated with diabetes. If you screen a patient with type 2 diabetes, the majority will have a fatty liver. And so in some patients with this fatty liver, they progress to cirrhosis, and this becomes an end-stage liver disease. What was previously called cryptogenic cirrhosis is now understood to be caused by non-alcoholic fatty liver disease, which is nothing but a sign of insulin resistance. So sexual dysfunction, as Professor Sam G. P. Moses would call it as a secretive complication of diabetes. Some studies they say that complication, sexual dysfunction, we mean to say that in men it is nothing but erectile dysfunction. In women it is nothing but a lack of lubrication. So this is what it is. It might have psychogenic causes also, because it involves two partners. It might have psychogenic causes also. When the psychogenic causes are ruled out, and when that's purely organic cause, sexual dysfunction, it is a very common complication. Some authors say that it might even be as common as diabetic neuropathy in a population, but the patients are not disclosing it. So that is what happens. So this is a quite common complication. And erectile dysfunction means nothing but an endothelial dysfunction. Erectile dysfunction occurs due to endothelial dysfunction in the corpora cavernosa, everything. That is because of a defective ability to maintain the erection because of the affection of the nitric oxide pathway. So it means that endothelial dysfunction indirectly means that the patient is prone to coronary artery disease and all the other macrovascular complications. So this is ED, the presence of ED is an indirect or a surrogate marker of the risk of developing coronary artery disease. That is what you have to understand as diabetologists. So cancer risk. So what about cancer risk? It is something like two school of thoughts exist. Diabetes, the risk of diabetes also progresses with increasing age. The risk of cancer also progresses with increasing age. So this could be a coexistence. But as we see, many pancreatic cancers are also being associated with diabetes. But that could be due to because the pancreas is affected, diabetes being caused. That could be a causal effect. But on the other hand, when we see breast cancer, we see carcinoma endometrium frequently associated with diabetes. Among the drugs used for diabetes, insulin is pro-carcinogenic actually. Because of its action through the mTOR pathway, insulin is actually pro-carcinogenic. There are some authors who say that insulin is dangerous to use because of its effect on cancer, etc. And insulin glargine also got into a turmoil some point of time ago because of its an allegation of pro-carcinogenic effects and all. But overall, considering this, we cannot demonstrate it clinically, because to achieve glycemic, if we don't achieve glycemic control also, it is going to harm the patient. So we don't give much importance to that on practical purposes, and it is just a suspicion only. It is not a well documented effect also. Among the anti-diabetic drugs, metformin is anti-carcinogenic. Metformin decreases the risk of developing cancer, especially colorectal cancer. It has been shown that metformin decreases the risk of developing colorectal cancer. And finally, many diabetic patients have some kind of depression or some kind of anxiety or some kind of psychiatric effects. And in type 1 diabetes, it affects their day-to-day life and their marital life and the way they carry themselves, the confidence, everything is affected, especially when the patient is type 1. In type 2 also, the patient might have so much of depression, etc. And especially this depression comes into picture. I wanted to highlight this, suddenly I remember. This depression comes into picture, especially when the patient's food intake is being targeted by the relatives or the doctor also. The patient should not be made to feel that he is doing some crime by eating what he wants or something like that. The patient is fine all of a sudden he develops diabetes, which the patient should not feel that is a punishment. And there are many relatives who mock the patient or who criticize the patient that they are eating too much and they are having no control. All these things will have only a negative impact on the patient. So as the treating physician, even though when we talk about a good diet or a proper diet for the patient, we should say it or we should put it in a positive way so the patient doesn't get depressed. So everything holds in the picture. And in surgical sites also, sometimes the surgeon says you eat 3 times a day chapati. Doesn't work any good. So it actually increases the depression and probably it increases the cortisol levels, increases hyperglycemia only. So proper diet is different and accusing the patient is different. So this should be taken care, especially by the relatives as well as by the physician. Coming to the assessment evaluation, I will go through in fast. And assessment, we have to have a detailed history, coming to ask about the symptoms of hyperglycemia, symptoms specific to the complication, history of comorbidities like hypertension, hypothyroidism, history of drug intake like especially steroid, personal history we have to concentrate, for example, erectile dysfunction. And a thorough examination, especially you have to check the peripheral pulses, any obvious infection like tinea corporis, dental caries, melanopathitis in the male, or vulvovaginal candidiasis in the female. BP measurement is very, very important. In every visit we have to do a BP measurement, and if we are suspicious, we can repeat the measurement also. But if the patient is hypertensive, we have to start the treatment. and the ankle brachial index measurement and cutaneous lesions should be looked for, and coming to the systemic examination. And the foot examination is specific in a diabetes to inspect for any dryness, loss of hair, dilated veins, cracks and fissures, all that might indicate a diabetic autonomic neuropathy. We have to examine the posterior tibial as well as the dorsal spinalis pulses, sensations like pinprick sensation, temperature, more importantly vibration, joint positions to be assessed. This is a common monofilament test. This monofilament test is an easy to perform test. This is a 10 gram monofilament. The 10 gram monofilament is an objective and simple instrument. It is used in screening the diabetic foot for the loss of protective sensation. This is nothing but a thin filament. It is called a 10 gram monofilament, and it is actually horizontal, that it is not buccal. And the examiner, in these pressure points, especially the great toe, here the ball of the great toe, little toe, the metatarsal, the edges, the heel, etc. These are very critical points. And the patient and the examiner applies the monofilament over these areas, and he applies gentle pressure just enough to buckle the filament. Suppose if the patient is not able to feel the monofilament when the filament buckles, it means that the foot is an at-risk foot, an insensitive foot. It might develop into diabetic foot. And there are little advanced technologies like biothesiometry or vibration perception threshold testing, handheld Doppler, etc. And fundus examination. If we are confident we can do it, or better to refer to an ophthalmologist to have a detailed examination at least once in a year. And investigations like blood sugars, HbA1c, RFT, LFT, thyroid test, urine albumin, lipid profile, ECG, echo, ultrasound abdomen. Coming to the screening. So this is quite important from the clinical point of view. When to screen for complications in a diabetes patient? This is asked by almost everybody. Type 2 diabetes, according to guidelines, type 2 diabetes, the complications should be screened for or should be looked for at the time of detection of diabetes. This is why? Because type 2 diabetes is a asymptomatic disease for a long time. It could be present even a few years before the detection of diabetes. So the complication might have developed at that time. At least in the initial stage, you have to screen for complications at the time of detection of diabetes. In type 1 diabetes, usually it's an acute onset. So the guidelines say that for the complications to occur, at least 5 years of hyperglycemia should be there. So they are asked to screen after 5 years of duration, but it is not a compulsion. What they are saying is a minimum of 5 years. And when to screen for comorbidities, hypertension should be checked for every visit, and this investigation should be done periodically. Coming to the management, early screening, early detection, and effective management of diabetes and other comorbidities and the complications. Good optimal glycemic control of blood pressure, dyslipidemia, specific therapies, for example, ACI inhibitors and ARBs to retard the progression of albuminuria. And if everything is done and the patient has got complications, what to do now? We have to go for limitation of the disability and minimizing the already existing damage. For example, this is a picture of fundus pan-retinal photocoagulation, where they have done a photocoagulation of the fundus because to prevent the progression of retinopathy and to retard the progression of this proliferating diabetic vessels to invade more and more of the retina. So they have to take such a measure. And here we also have so many diabetic footwear, etc. But suppose the patient develops ulcer, there are so many footwear like offloading footwear, casts, etc. Customized insole casts, etc. are available. This is disability limitation, an example I am showing. And this is renal replacement therapy. If the patient develops kidney disease, DKD, chronic kidney disease, dialysis is done and transplant might be necessary. And having seen all this, we should finally understand what is the importance of intervention, why we should intervene at the earliest. And this is the point. Risk factors associated for cardiovascular disease in any individual, it tends to cluster in individuals. It is not that any individual has got only diabetes, another individual is only a smoker, another patient is only hypertensive. It's not like that. So one patient might have more than 2 or 3 risk factors. Diabetes, hypertension, high cholesterol, obesity, everything go hand in hand, and smoking is a preventable risk factor. And we should also understand one point, that about 40 to 50% of all diabetes patients have hypertension. And the reverse is also true. So that is why it is quite essential to screen for hypertension. And diabetes increases the risk of CV diseases by 2 to 4 times. And as we saw in the earlier slide, risk factors tend to cluster in individuals. So the individual might also have hypertension, dyslipidemia also. And in such risk factors, the risk is multiplicative, it's not additive. Suppose if the patient has got two risk factors, diabetes increases the risk by 2 to 4 times. And so, for example, hypertension increases the risk by 3 times means it is 2 into 3. So the risk is multiplicative. That is how we have to understand. So that is why aggressive identification of the risk factors and aggressive management of the risk factors is also important. And as I said earlier, endothelial dysfunction is a marker of potential heart disease. Albuminuria, as we pick up in when we screen for nephropathy, it's a marker of endothelial dysfunction. Even the simplest erectile dysfunction might correlate with the serious cardiovascular disease. And studies like UKPDS and DCCT have shown how much benefit a single percentage of HbA1c reduction might have in microvascular complication reduction. And there are things like legacy effect of metabolic memory, that is starting from the early point of time when we have a good glycemic control, and after a particular point of time, after a particular few years, suppose the patient might be lost to follow up, or the glycemic control might not be as good as earlier. Even then, there is something called a legacy effect or a metabolic memory which lessens the risk of developing complications in such patients. And the prevention, as I said, early screening and detection, optimal glycemic control, HbA1c, time and range, and the target should be individualized. We have to take care to avoid hypoglycemia and glycemic variability. And this is a very frequently asked question: is there any way to prevent the progression from pre-diabetes to diabetes? The most effective intervention is lifestyle modification. Intensive focused lifestyle therapy is shown to prevent the progression from pre-diabetes to diabetes in a large study called the Diabetes Prevention Program, followed by metformin and sometimes acarbose also. And prevention of progression from micro to macroalbuminuria, sometimes it's possible, especially when good glycemic control, good BP control, and with some drugs like SGLT2 inhibitors. And reversal from pre-diabetes, that is the patient is having IGT, is having pre-diabetic stage, HbA1c of 5.7 to 6.4. Is it possible to revert back to normal glycemia? Yes, it is possible with intensive lifestyle measures, weight reduction. Suppose the patient is overweight and he loses about 5 to 10% of the body weight, he might revert back to normal glycemia. Why we are focusing is everything is will retard the onset of complications of diabetes. That is why we are talking about the prevention aspect here. And periodic and regular screening of comorbidities, periodic and regular screening of complications, health education, motivation of the patient, repetition of what we said in the earlier visit, and emphasizing everything is important. It's nothing but a repetition and motivation only. And foot care, we have to wash the foot daily. We should look for any ulcers. We have to cut the nails in a flat manner. We should not cut here at the edges, and we should look for any fissures, cracks, and examine the bottom of the feet with a mirror. And we have to know and track what we find. And to put it simply, for the care of the foot, we have to care the foot like the face. And finally, coming to the recommendation of statins, for primary prevention of cardiovascular disease in a diabetes patient, especially over the 40 years of age, statins are strongly recommended. Coming to the role of aspirin, there are two schools of thoughts. Some people recommend it, some people do not recommend it. So finally, in diabetes complication, prevention is always better than cure. Thank you.
Thank you, sir. Anybody have any doubts?
Yeah, you said alcohol causes hypoglycemia in one slide. Actually, I thought alcohol causes hyperglycemia.
Sometimes these alcoholics, they take they binge drink, they fall flat, they also take the OHS, they do not take the drugs, milks properly. And we have seen so many alcoholic patients. Alcohol causes hyperglycemia probably because of the involvement of pancreas. But in the acute effect, so all this, the chronic moderate drinkers won't have any problem, like what the Westerners do.
In fact, they overeat after. After alcohol, they overeat.
That depends on the individual. But sometimes, suppose he is taking a strong oral hypoglycemic agent like libenclamide, and it takes alcohol, they develop hypoglycemia, and sometimes they fall on the ground. It happens.
Another thing you said was on fatty liver. Now you see any ultrasound you do, they send a report to fatty liver. What is this? I mean,
because of the insulin resistance that is present in majorities. Usually in type 1 diabetes, if you see, we will not see that fatty liver. In type 1 diabetes, if you see some increased glucose, that could be usually not a fatty liver. That in type 1, just an illustrative example. In type 1 diabetes, where there is an absolute insulin deficiency, and I am giving the type 1 diabetes is lean, I am giving insulin from outside. And especially in the early stages, if I screen for the fatty liver, I will not see a fatty liver. That is because of the insulin deficiency. Sometimes if there are increased echoes, that is could be due to a condition called glycogenic hepatopathy that can occur in a type 1 diabetes. That's called a Mauriac syndrome. Sometimes the type 1 diabetes becomes, because of the insulin injection, he becomes fat, he becomes overweight, and he develops insulin resistance. And at that time, he might develop insulin resistance. At that time, he develops what is called double diabetes. At that point of time, he might develop a fatty liver. In other words, what I try to say is fatty liver is nothing but a surrogate marker of insulin resistance, which is widely present in the population.
What is the role of nephrosave in diabetic nephropathy?
Many nephrologists prescribe that, madam. It could be given. It could be given. Still, it could be given. Such supportive measures are encouraged only.
And one more thing is, when you're looking at screening for by albuminuria for diabetic nephropathy, which one is the best one? Is it a spot one or a 24-hour, or is it albumin creatinine ratio? If you go for one, which one would you go for?
So suppose if I should have one gold standard, that is a 24-hour urine sample, and if I can't do it, I should have some control over what I'm checking. It's better to go for the ACR, the albumin creatinine ratio.
Okay.
And if both are not
70 means, then it becomes.
That depends on the lab value also. So some values have different references. There's something called an excretion rate also. If I have nothing, then I go for a simple urine albumin. And if that urine albumin is negative, I can go for urine microalbumin. The gold standard is 24 hours. If we are an institute, the patient is motivated and the patient could collect that urine in a can for 24 hours. If gold standard is 24 hours.
Yeah, but if that is not possible,
ACR is a better thing compared to a plain urine albumin secretion, because it has got some control with the creatinine. So the ACR will be a better thing.
Thank you very much.
Estimation of EGFR would be better, much better, no? More accurate.
Yeah, EGFR monitors also.
Yes, sir. EGFR is better, sir. Better to have a EGFR in the mobile.
Yeah, it's very there.
Yes,
So
sir.
you can monitor deterioration.
Much better and easier also.
Use collection is very difficult.
Yeah.
This is for early detection.
No, the earliest spotting.
Early detection EGFR is very good.
No, if I am going for a urine test, I wanted to know which one would be the best. Spot.
Thank you, sir. I request Dr. Girija ma'am to honor our speaker.